Hi everyone, so for another installment of Anesthesia Worst Case Scenarios. This is a case I've just created about a patient with small bowel obstruction, also thyroid disease. So we're just going to go through so many different problems in this, just to try and get as much out of this scenario as possible. So imagine you're called down to review a patient for the evening emergency list in your tertiary hospital. And usually when it says tertiary hospital, this means it has an ICU and it's got a lot of capabilities. You have a 60-year-old female with small bowel obstruction for laparotomy who looks unwell. What do you do? And so as soon as, a lot of medicine is about having really solid structures. And the very first structure is, what do you do, when you assess a patient? And the very first thing I think is, generally speaking, we're always going to go history, examination, investigations. But as soon as the patient is unwell, or I'm not sure how well they are, then I'm going to go straight for a top to tail ABCD or primary survey approach. So because this patient is clearly unwell, I'm just going to forego the history examination investigations and forego that for a primary survey and then maybe secondary survey with an ample or very focused history. So let's go through that. So look, I'd immediately attend the patient, go down to emergency, and then while mobilizing resources asking for help, I'd check for danger. Obviously, I'll check the usual things for that. Checking for a response, I'd try to speak to the patient. Assuming that they're speaking to me, I can already see that the airway will be patent. So after response, I send for help, and obviously I'll try to get the trauma team, or sorry, not the trauma team, but the other team members in emergency and surgery and any relevant medical teams around me and other support. For breathing. Now for breathing, in the ALS course we run at with the Australian Resuscitation Council, we talk about the mnemonic RATES, RATES, and I find this really useful for just getting through my breathing section in a quick fashion. So respiratory rate, A for auscultation, T for tracheal deviation, E for effort of breathing, and S for saturation. So I immediately mobilize my resource and I check these variables and then see what the examiner volunteers. And so in this particular example, the respirator is 30, the sats are 92% on room air, for which I'd then apply Hudson mask oxygen at 6 litres. Trachea is normal, effort is increased with the respirate, and the saturations are 92%. Sorry, on auscultation, let's say that there was bilateral wheeze and some coarse crackles at the bases. Good, so because of the wheeze, I'd probably institute nebulized salbutamol and Atrovent or ipratropium bromide as well at that stage. Then I'd move on to circulation. So I'd ensure that the patient had 2 large bore IV cannulae, let's say 16 or 14 gauge. At the same time, I'd take bloods and a full panel of bloods, including FBE, UEC, coags, group and hold, CMP. And also, depending on the other factors, if this patient has small bowel obstruction, maybe I'm concerned they're septic, I might take blood cultures as well, and a venous gas for a quick result. Good, so I then ask for the circulation obs, so heart rate, blood pressure, and then I might check for other signs of fluid status. And depending on what's going on, I'd offer looking at the JVP, central capillary refill, and general look at the patient's perfusion and mucous membranes. I'll try to note how much fluid was given as well. And so the examiner would offer in this circumstance, yes, 2 large bore IV cannulae, 16 gauge iron QB fossa, heart rate is 130, blood pressure is 100, and 2 litres of crystal has already been given. So this patient already looks pretty unstable with a rapid heart rate and a blood pressure of 100. So I'd give another fluid challenge, another 250 to 500 mils to see the response. At a heart rate of 130, I'd want to check the monitors to make sure it wasn't an altered rhythm, but you can assume that this would be sinus tachycardia. I'm also thinking at this stage that this person probably needs to go up to theatre quite urgently, and I'm thinking of that. For D for disability, I'm generally thinking of gross neurological function, motor function, pain, and conscious state. So the examiner then offers GCS 15, pain is 7 out of 10 due to the abdomen, and they've had a total of 10 milligrams of morphine IV given by the paramedics and the ED in the last couple of hours. Good. At this stage, I ask for the temperature as well in disability or exposure, and the temperature is volunteered as 38.5. So I say, look, this patient is obviously septic as well as having this bowel obstruction, and I'd institute broad spectrum antibiotics, and immediately I'd offer what I'd recommend starting at. So either ceftriaxone and metronidazole, or in some institutions that might be tazocin, but I'd just go ahead and offer that information as well to get through the viva quickly. For exposure, I'd ask to see the patient, check the weight, the height, the BMI, and any other notable things, but especially pertaining to the abdomen, because that's a pathology. In this particular example, the examiner offers they're 80 kilograms, 150 centimeters with a BMI of 35. They have a large goiter. So immediately once they've said goiter, I'm now thinking, okay, well this is now a substantially more complicated picture, because now I need to really assess what's going on with the goiter. I'd take thyroid function tests and try to ask the patient about the things I'm worried about. So with a goiter, a thyroid mass, I'm worried about really just these things. Mass effect on respiratory and vascular structures, whether they're euthyroid or not, because a thyroid toxicosis or a potential thyroid storm is a catastrophe, and malignancy, because malignancy will change all the dynamics of how that tumor interacts with the other tissues and how well I can get a tube past. In this particular example, the examiner then offers, as there's no signs of any mass lesion, the TFTs are on their way. You're not sure about, this patient has not been investigated, no GP follow-up, and pretty much has been lost to follow-up. Good, so I'm just waiting on the TFTs. In spite of this, I think we need to proceed because this patient is very unwell and needs operative management. Good, so after I've asked that, I would immediately start mobilizing for theatre to be ready, and also talk to ICU for post-op. I'd also follow up with the fact that I'd want to take an anesthetic history, and I'd do a full history as appropriate, especially an airways, and then looking at any other disease states for optimization. So apparently they're a heavy smoker with COPD, multiple presentations to ED with bronchitis, and irregular puffer use. No GP, normal airway, and the examination shows wheeze, so you've already instituted salbutamol and ipratropium bromide on the way up to theatre. So next question, what's your plan for OT, or what's your plan for theatre? And so I'll try to think of this in as focused a way as possible. Essentially, this is a small bowel obstruction. I'd do a rapid sequence induction, I'd want an art line, and potentially I'd place a CVC later on, knowing that this patient might have a long operative course and need ICU post-operatively. Because they're a thyroid patient, I'd be mindful that they might have abnormal thyroid function, so I definitely want a temperature probe, I might want a urinary catheter placed, and the surgeons usually take care of that. And with proptose eyes, I'd want to make sure that there's good eye care as well. And those are essentially the main points of this. What's your induction? So I'd ensure that this patient is a septic patient, potentially unstable during induction. So I'd want a fluid load, measure the outline, and I'd give a cautious induction with midazolam and propofol, let's say, 2, 3, 4 milligrams of midazolam, maybe 50 milligrams of propofol, 100 of rocuronium with metaraminol bolus and a metaraminol infusion, knowing that this patient is likely volume deplete due to the sepsis. The examiner offers that the blood pressure falls to 70 millimeters mercury. What do you do? And so this is an example of 70 isn't a crazy reading for the blood pressure to fall after induction. And what you find is that the examiners want to test you on small things. You know that if there's an arrest, you just follow the ALS guidelines, and that's not a thing that really differentiates a lot of candidates. But showing what you do in the gray areas is far more important for analyzing your decision-making skills. So the blood pressure falls to 70, what do you do? Look, I would offer, this is most likely the induction in a volume deplete septic patient. I would check the reading, scan my monitors, the patient and the surgery, and then just to institute some temporization measures like a fluid bolus and a 0.5 milligram bolus of aramine, and increase my infusion rate, and then be vigilant for other signs of problems. Obviously, I might offer, if I'd check for other signs of anaphylaxis and optimize the sepsis at hand as well. It is then offered that the blood pressure recovers. It is a difficult operation, lots of adhesions, and then 40 minutes into the operation, you notice that the temperature is now 41 degrees. What do you think is happening, and what do you do? So this is obviously really concerning, is the first thing I'd say. 41 degrees is, in such a short time frame, is unusual, but it does fit with the septic picture. I would check the reading, scan my patient, surgery, and the monitors, and check all those readings to try to ascertain what's going on, and I'd institute cooling measures because that temperature is getting elevated. I might turn off the bear hugger, turn it to a 32 degree rate with the bear hugger, and I might use the theatre cooling or other cooling packs, ice packs at various points if I was very concerned about this. So I'd be worried that this might be MH in this particular circumstance, but then the examiner offers, the end tidal is 30, the ventilation is 6 liters per minute, so pretty standard, and the blood pressure has risen to 150 on 100 and a heart rate of 150. I'd volunteer now that this is concerning. I'm worried if this is due to some level of awareness or lack of analgesia, which I would institute. And if then I was prompted the fact that this is not relieving the problem, I'd be concerned that it was thyroid storm as well. I'd then check for the lab results. The lab results are then offered, funnily enough, in this worst case scenario that there's high T3 and T4 levels are high, but the TSH is low. What do you make of this? So this is very concerning. These are high levels showing that there's high free thyroid hormone, but also there's negative feedback on the pituitary because of the low TSH. And the likely diagnosis is thyroid storm. So what is thyroid storm? Thyroid storm or thyrotoxicosis crisis is a life-threatening exacerbation of a decompensated or pre-existing hypothyroid state. And some of the signs and symptoms of fever, tachycardia, tachypnea, congestive heart failure, atrial fibrillation. And this is not a common disease, but there's a lot of severe signs that can manifest. The examiner might go on to ask, what is the treatment? And look, a good format for this pretty rare condition is supportive treatment, reduction in synthesis of thyroid hormone, reduction of peripheral conversion of T4 to T3, and then decrease the metabolic effects of thyroid. And then there's some other things such as plasma exchange as well. So again, cooling the patient, hydration, oxygen, ventilation. These are the standard supporting things that you'd be doing naturally in this situation for every patient. Reduction in synthesis, and know that a lot of the stuff here is oral medications and not everything is IV. So I've just looked up a few of the IV medications for this, but Dexamethasone 4 milligrams every 8 hourly, or hydrocortisone 100 milligrams every 6 hourly. Iodine, so sodium iodide can be given as 1 gram IV, but often they talk about Lugol's solution or supersaturated potassium iodide. There's also carbimazole, which can be given enterally, but IV methimazole, methimazole, 20 milligrams for 4 to 6 hourly IV is the IV equivalent. And there's also propylthiouracil, and that's given orally 200 to 400 milligrams every 6 to 8 hours. That's reduction of synthesis of thyroid, reduction of peripheral conversion of T4 to T3, can be propylthiouracil or hydrocortisone, as well as propranolol, 80 milligrams orally 6 hourly, or 5 milligrams over 10 minutes IV, and you can repeat that maybe 3 times PRN. Now in this particular case, we've got a patient with unstable, severe, or an exacerbation of COPD as well. So non-selective beta blockers, really not a great idea. So I might offer, I might say something like, look, appreciating the risks, and again, the statement of trying to anticipate what the what the examiner is going to say, I think shows a level of intuition about the scenario. Appreciating the risks of a beta blocker in a patient with COPD, this is a crisis at hand, and I'd probably institute measures with using esmolol as a short-acting and rapidly metabolized beta blocker in case it has some harmful effects. I would then maybe replace that with metoprolol, depending on how that goes. There's also the chance of using IV diltiazem, and any other drugs that can lower blood pressure and slow the heart rate might be useful as well. It's interesting, when I was looking at these cases, there are case reports of the thyroid crisis being mistaken for malignant hypothermia and then being successfully treated with supportive measures and dantrolene. So just an interesting thing again. So I've instituted that management. The surgeon offers that, great, the surgery goes on, it's completed at 4 hours, and at the end of surgery you notice a red mark on the cornea where you tape the eyes, but due to the proptosis of the eyes, they didn't close correctly. What do you do? And this is just a small, it's a small thing, but it really needs appropriate management. And the principles are really reporting to an incident reporting system, such as RiskMan or WebAIRS as well. If you're, to volunteer it to the anesthetic risk monitoring space, I'd probably call my indemnity insurance as well as open disclosure to the patient. So those facets of this would be pretty important. Again, just a small thing, but it's not the most defining error that you could have, but it's still very important that you have a system whereby you report and openly disclose this. The viva goes on to say she has a 3-week stay in hospital, but again is lost to follow-up until she presents to you 3 months later. She's booked for a total thyroidectomy, and she has seen an endocrinologist and surgeon for her multinodular goiter. What do you want to know in assessment? So again, I do my usual assessment, but this patient can be particularly challenging considering that we know that she was unstable with her COPD, she's a smoker, and she has this large goiter. So now this goiter has grown, so I would do, again, a complete anesthetic assessment, assess the severity and stability of her COPD, and institute good management for that with a regular arrangement of puffers and or steroids, and a respiratory physician ideally. I'll check the goiter as well. So again, the things I'm most concerned about with an enlarged thyroid mass is compression of respiratory structures and vascular structures, and I'd again do a history examination investigations to check this. Specifically, I'd want a CT of the neck, and let's say there is a constriction. I want to know these facets of that constriction of the trachea, and these are the smallest diameter, the length of that constriction, and also how far above the carina it is. Because really what I want to do is I want to be able to get that tube past the blockage and be able to ventilate this patient satisfactorily. If there was signs of any cardiovascular compression, and these are often of the low pressure structures, these would be things like the right atrium, the pulmonary vasculature, the superior vena cava, which might be alluded to on examination and history, such as, for example, with Pemberton sign, as well as the patient reporting collapse or syncope or any other cardiovascular symptoms. I'd then, again, look for a functional echo or some kind of CT to show that occurring. I'd also want nasendoscopy just to check for any vocal cord issues, which might be really important for the intubation and post-operative recovery. Final aspirate would also be something that I'd check that the surgeons would have organized. I'd also ask for malignancy potential of this, because again, the fact that you have an invasive or malignant carcinoma will again change the dynamics of that mass on the space, its movability, how easy I could pass the tube, and also how invasive it was of other structures, including the trachea and the risk of tracheomalacia afterwards. So my anesthetic plan, they might ask, what is your anesthetic plan? And again, I'd offer a number of things, but prior to this, I'd want smoking cessation, but this would be a general anesthetic. I would try to avoid muscle relaxation at the time that they were stimulating the recurrent laryngeal nerve. So I'd offer that I'd want to place a NIM tube, but that this might actually be complicated. If you were to describe a NIM tube, it's a flexible, reinforced tube that has the electrodes placed to allow the surgeons to be able to monitor recurrent laryngeal nerve function. But those electrodes have to be placed between the vocal cords. And so this might be tricky if you have a mass-occupying lesion that you need to get past. So what do you do? Let's have a think about that. And in terms of lateral thinking, what we've done in the past is remove that tape of the electrode and just pass it up the tube. This is something you can probably measure and check to make sure that you've done it right. Good. I'd also talk with the surgeons about what's relevant for them, their positioning issues, how long the surgery might be, how complicated it might be, the risk of tracheomalacia. But otherwise, this would be a standard general anesthetic with looking after those things. The next question, what are the complications of large thyroid surgery? So yes, hemorrhage. Obviously, we're always worried about post-operative hemorrhage and a neck bleed, recurrent laryngeal nerve palsy, tracheomalacia, and laryngeal edema. During the operation, the surgeons ask for Valsalva. What is this and how do you do this? So Valsalva is to check for venous ooze or venous bleed and the adequacy of hemostasis. What I do is I manually increase the bag pressure to about 30 to 40 centimeters water, and usually it's for about 5 to 10 seconds, and the surgeons will then ascertain whether there are any problems and then say that's fine. What do you give for analgesia? So my first thought about this question is that it's not usually that painful. It's a very small incision. The surgeons put long-acting local anesthetic in the wound, so I'd just use a multimodal approach, local in the wound, paracetamol regularly, occasional tramadol and endone, but I'd also ask if the surgeons are happy with a selective COX-2 inhibitor like celecoxib. So that's just a standard question. There's nothing too tricky about that, and in thyroid management, it's never, in my experience, something that's caused a massive problem unless they were a chronic pain patient with some other issue. So this situation then goes further. Again, this lady's having there's a worst case scenario. This is a lot of badness is happening here. So you're on call that night and you attend the code blue on the endosurgery ward. Your patient is blue and the neck enlarged. Nothing else has happened. You're one of the first people to arrive. What do you do? So again, I want you to think through this and think how this differs to the first situation where you attended this patient in emergency and you had time to do a top to tail approach. This is far more dire. I would immediately attend the patient, knowing that this could be a potentially catastrophic, immediately life-threatening situation, and it's a crisis. I'd immediately assess the patient's response and their airway, because that's what's most at risk in this situation. Let's say the examiner offers the patient doesn't look like they're breathing, it looks very dusky and blue. I would immediately ask for the kit, the neck suture kit, and immediately cut the superficial, horizontal sutures, and then also the deep strap muscle sutures to release the pressure. That's the first thing I need to do. So just imagine that I didn't go through this very formal top to tail assessment. This was immediately life-threatening right there. I have no time to do that, so I go straight for the solution, which is to cut the sutures to release the pressure. The examiner offers that there's lots of bleeding, but the patient looks better and is now breathing rapidly. I'll then offer that this is a crisis. I'd lead the situation, I'd stabilize the patient while getting ready for immediate transfer to the OT. What stabilization would mean was that as leader, I would try to mobilize my resources to someone managing the airway with bag mask, ventilation and oxygenation, and supporting them in a head-up position. I try to institute as much monitoring for transport as reasonable, a pulse oximeter, blood pressure and ECG, and cycling the blood pressure frequently. For circulation, I was again ensure that there was still cannula in. I hang a bag of fluid and run that, knowing that this patient is likely to have a decent amount of blood loss. And I'd also prepare theatre for that fact that we might need a level 1 and might need to call blood bank and hematology, which I'd do on the way or assign someone to that task. Then I'd transport to oxygen and get someone to call the surgeon for immediate tending to the surgery to remedy the situation. And that's about it, really. I just need to go through the most vital things, knowing that the end point for this problem is directly down to the theatre. What do you do for induction? So this would be a very difficult induction, depending where the bleeding is. If there's internal bleeding, things would change dramatically. So I would do a rapid sequence induction, have the patient well positioned. I'd note the previous grade, but note that this will be more difficult, and I'd use a video laryngoscope. I'd also have 2 suction ready, just in case there's internal bleeding in the larynx as well. This is unlikely, but I'd just offer that as well. And then I go ahead with my induction with usual propofol, high-dose rocuronium succinylmethonium, and alfentanil 500 to 1,000 micrograms. And that's where this viva ends. Again, hope you enjoyed. Please comment below if there's anything else you disagreed with or have done in your experience. Please volunteer that. I've actually never managed a thyroid storm case, and I think it's a very rare thing to occur. There's only a few case reports that have been published, so yeah, any comments would be appreciated on that. Thanks very much.